On behalf of Children and Family Futures and the Family Drug Court Learning Academy, welcome to our webinar presentation. Special thanks to the Office of Juvenile Justice and Delinquency Prevention, who supports the National Family Drug Court Training and Technical Assistance Program. For more information about Children and Family Futures, the Learning Academy, and the Family Drug Court Training and Technical Assistance Program, please visit our website at www.cffutures.org. We hope you find this presentation helpful as you strengthen your partnerships and improve outcomes in your family drug court.
Hello, my name is Katie Ryan, and I want to welcome you to our presentation, Planning for Safe Care, What Your FDC Needs to Know About Serving Women Affected by Opioid Use Disorders and Their Infants. This presentation will highlight 5 important things you need to know as a family drug court practitioner about serving pregnant women and infants affected by opioid use disorders. In this presentation, we will highlight the importance of a collaborative approach to engaging pregnant women with opioid use disorders into prenatal care, medical care, substance use treatment, and planning for the safe care of the baby and the family, all with the goal of reducing the level of crises for women, babies, and systems. Why is this so important? Nationwide, we continue to see an increase in the foster care population, particularly infants affected by parental substance use. The opioid epidemic is drawing both public attention and federal resources to address their damaging effects on individuals, families, and communities. Additionally, the direction of public policies and resources are increasingly focusing on the goals of prevention, early intervention, and keeping kids at home with their families. These federal investments and legislative action will certainly open opportunities for family drug courts. This video presentation will serve as a starting point for FDCs as they begin to consider how they can best serve mothers and infants affected by opioids. For those of you who are not implementing a family drug court, this presentation will offer useful information about serving this important population. This presentation will also highlight a couple of resources that your team will find particularly helpful. First, we're offering a team discussion guide that provides some questions to explore together after viewing this presentation as a team or on your own. Second, the publication, A Collaborative Approach to the Treatment of Pregnant Women with Opioid Use Disorders, jointly published by the Children's Bureau and Substance Abuse and Mental Health Services Administration, is a valuable and comprehensive resource for any team serving this population. You can download these resources on this presentation's webpage, located on our website, www.cffutures.org. So let's get started. When serving pregnant and parenting women with opioid use disorders, it's important to remember that timing matters when ensuring immediate and ongoing services for pregnant and parenting women and their babies. The National Center on Substance Abuse and Child Welfare has developed a 5-point intervention framework which identifies 5 major timeframes when intervention in the life of a mother and their infant can help reduce the potential harm of prenatal exposure. First, pre-pregnancy. During this time, intervention can include promoting awareness among women of childbearing age and their family members of the effects that prenatal substance use can have on infants. Prenatal. During this time, healthcare providers have the opportunity to screen pregnant women for substance use as a part of routine prenatal care and to make referrals that facilitate access to substance use treatment and related services for the women who need these services. Birth. Interventions during this time include healthcare providers testing newborns for prenatal substance exposure at the time of delivery and connecting mothers and infants affected by substance use to necessary resources to support their treatment, recovery, safety, and well-being. Neonatal. During this time, healthcare providers can conduct a developmental assessment of the newborn and ensure access to services for the newborn as well as the family. Throughout childhood and adolescence. During this time, interventions include the ongoing provision of coordinated services for child safety and well-being, as well as continued support for their parents' substance use treatment, recovery, and parenting support needs. It's important that treatment services and ongoing supports for the mother continue from the birth event through each developmental phase of the child. Each of these intervention points open windows of opportunity for multiple agencies to work together to improve outcomes for mother, her baby, and the family. Cross-systems linkages are necessary to ensure services are coordinated across the spectrum of prevention, intervention, and treatment on their behalf. For more information about this framework, I would encourage you to view our 20-minute video presentation entitled A Framework for Intervention for Infants with Prenatal Exposure and Their Families, which we have posted on our webpage. The prenatal period in particular opens up important opportunities to improve outcomes for both the mother and baby. The key takeaway here is that the birth event is only one of several opportunities to affect outcomes. These outcomes include healthier pregnancies, healthier children, safe families, and a greater chance of remaining together. During the prenatal period, a mother is oftentimes more motivated to make health-related changes. Prenatal care is a touch point for services. During routine prenatal care, physicians can initiate the following: universal screening using an evidence-based tool for substance use disorder and opioid use disorder as a part of routine prenatal care, and to make referrals that facilitate access to treatment and related services for the women who need these services. Early identification can minimize potential harms to the mother and her pregnancy while capitalizing on the unique motivation for change that pregnancy can bring. A universal approach is important here, since selective screening based on risk factors such as socioeconomic status or race perpetuates discrimination and misses most women with problematic use. Engagement of systems to facilitate early engagement and advanced planning for the treatment of pregnant women that addresses safe care for the mothers and their newborns can help prevent unexpected crises at the time of delivery. This would include acknowledgement of medication as a possible key component of treatment and also educating the pregnant mother on the risks of neonatal abstinence syndrome. Pregnancy often motivates women to seek help with their substance use disorders, opening numerous windows for supportive intervention. Assessment: adequate time for comprehensive assessment of family strengths and challenges and planning for the array of services to be provided. Linkage to services. The provision of services by the child welfare system 30 days prior to the child's birth can be one of the most significant and beneficial systems-level changes that can be made. Communication amongst partner agencies ensures that providers who are part of the treatment team are willing and able to share information on the progress of families and any concerns. Efficient communication across service systems, agencies, and professionals is critical. Sufficient communication ensures that families have necessary supports and infants with prenatal exposure have follow-up services to address their safety. Next, let's talk about the pregnant mother affected by opioid use disorders and the type of treatment she will need. First, key principles of treatment. It's important to have a comprehensive approach towards treatment. In other words, services to pregnant and breastfeeding women with substance use disorders should have the level of comprehensiveness that matches the complexity and multifaceted nature of substance use disorders. This means having appropriate levels of care and a full range of services such as individual, group, and residential substance use treatment programs for pregnant women. Clients with opioid use disorders should have access to mental health services as needed, medical care and addiction counseling, as well as recovery support services to supplement treatment. Treatment should promote and facilitate family, community, and social supports, as well as fostering strong links with available childcare, economic supports, education, housing, and relevant services. Effective treatment should also address the parent-child relationship. It's important to note that treatment is not recovery. The goal of treatment for opioid use disorders is remission of the disorder leading to lasting recovery. On the other hand, according to SAMHSA, recovery is a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. The domains of recovery include 4 primary areas: health, home, purpose, and community. Medication-assisted treatment is also known as MAT, a critical component for effective, comprehensive treatment for women with opioid use disorders. Mothers receiving MAT can benefit from individualized psychosocial supports, which can be provided through healthcare and other support services in the community. MAT stabilizes the woman and encourages connections to prenatal care. MAT also prevents withdrawal. Abrupt withdrawal of the woman from opioid medications can pose serious risks for the mother and baby, including inducing preterm labor, fetal distress, or miscarriage. As a result, MAT during pregnancy is recommended by health professionals, including the American College of Obstetricians and Gynecologists and ASAM, as a best practice and standard of care of pregnant women with substance use disorders. For those who need it, MAT should be readily available. Improving access to treatment with OUD medications is critical to closing the wide gap between treatment need and treatment availability, given the strong evidence of effectiveness for such treatments. MAT should be successfully integrated with all treatment settings, including outpatient and residential treatment. Some patients may benefit from different levels of care at different points in their lives, such as outpatient counseling, intensive outpatient treatment, inpatient treatment, or long-term therapeutic communities. Nevertheless, patients treated in these settings should have access to OUD medications. It's important to remember that there's no one-size-fits-all approach to opioid use disorder treatment. Not everyone needs medication. For some, recovery is achieved through medication, while some are able to achieve remission without OUD medication. Many people with OUD benefit from treatment with medication for varying lengths of time, including lifelong treatment. Some people stop using opioids on their own, while others recover through a support group with or without medication. As a part of a comprehensive treatment program, MAT has been shown to increase retention in treatment, decrease illicit opioid use, decrease criminal activities, rearrest, and reincarceration, decrease drug-related HIV risk behavior, decrease pregnancy-related complications, and reduce maternal cravings and fetal exposure to illicit drugs. I want to spend a few moments talking about the importance of reducing stigma for women seeking treatment for their opioid use disorders. Stigma surrounding substance use disorders can create significant barriers to treatment for pregnant women. For example, many mothers do not self-disclose their drug use during pregnancy due to stigma. In addition, when they do reach out for help, they often encounter misinformation, denial, inaction, and even judgmental and punitive attitudes towards their substance use. We would encourage you to talk to your team members about MAT and find out if all are in agreement. For instance, does everyone on your team agree that MAT should be made available to pregnant women? Also, do any believe that MAT is replacing one drug for another? It's important to identify any areas of disagreement and explore why, and offer training to resolve any misunderstandings or concerns. This process will ensure the entire collaborative team are non-judgmental and supportive of pregnant women with opioid use disorders and identify and change any policies or practices that are punitive and serve as barriers from entering and engaging in treatment to benefit themselves and their infants. Having these important discussions and provided needed and ongoing training will ensure that all the partner stakeholders and staff are prepared to work together towards a shared vision and mission. I want to move from the treatment needs of women to the needs of their infants. When pregnant women use opioids, their infants may be affected. Neonatal abstinence syndrome, also known as NAS, is the common term used to represent the pattern of clinical findings typically associated with opioids withdrawals in newborn. When pregnant women use opioids, their infants may be affected. Neonatal abstinence syndrome, also known as NAS, is the common term used to represent the pattern of clinical findings typically associated with opioid withdrawal in newborns. NAS is a complex disorder with many factors contributing to its incidence and severity. These factors include the type of opioid the infant was exposed to, the point in gestation when the mother used the opioid, genetic factors, and exposure to multiple substances. The symptoms of NAS include blotchy skin, difficulty sleeping and eating, trembling, irritability, sweating, and difficulty in soothing. These babies can suffer from diarrhea, slow weight gain, hyperactive reflexes, and increased muscle tone. When it comes to the treatment of NAS, there are non-pharmacological and pharmacological methods. The American Academy of Pediatrics recommends that newborns with NAS receive treatment using non-pharmacological means whenever appropriate. Non-pharmacological treatment seeks to soothe the infant's symptoms while also encouraging the mother-infant bond. Some of these practices include rooming in. Several studies have shown that rooming in for infants born with NAS with their mothers, rather than transferring them to the neonatal intensive care unit, may reduce the severity of withdrawal symptoms and hospital length of stay. The NICU environment may exacerbate infants' discomfort given the frequent noise, activity, and bright lights. Rooming in infants with their mother offers a dark, quiet environment and may reduce the severity of symptoms and length of hospital stay. Rooming in also helps new mothers bond with their infants and offer more opportunities for non-pharmacological supportive techniques, including swaddling, which involves snugly wrapping infants, swaying, and rocking the swaddled newborns to help calm their symptoms. Breastfeeding. Breastfeeding has been shown to reduce the severity of NAS. AAP, ACOG, and ASAM recommend breastfeeding for mothers receiving MAT for an opioid use disorder. In particular, studies have shown that when infants are breastfed rather than formula fed, they tend to have lower NAS scores, require less medication, and spend fewer days in the hospital. Breastfeeding may also delay the onset of withdrawal symptoms. This is in addition to other well-known benefits, including reduced risk of infection, obesity, and childhood leukemia, improved neurodevelopmental outcomes, improved maternal outcomes, and better mother-infant bonding. Interventions focused on non-pharmacological therapies, empowering messages to parents, and a simplified approach to assessment led to substantial and sustained decreases in average length of stay, proportion of infants treated with morphine, and hospital costs. Treatment that supports this parent-child relationship encourages retention in treatment, increases parenting skills and capacity, and enhances child well-being. According to the American Academy of Pediatrics, pharmacological treatment is indicated to relieve more severe symptoms of NAS when non-pharmacological measures have been unsuccessful. However, AAP cautions that unnecessary use of medications will prolong a newborn's hospital stay and may impede maternal-infant bonding. When medications are administered, opioid medications are the most commonly used option. Morphine or methadone is often the drug of first choice, followed by phenobarbital as a second treatment if necessary, particularly if the mother has used heroin during her pregnancy. AAP recommends that practitioners use a standard scoring method to assess symptoms and implement medications. The bottom line here is that babies who are exposed to opioids in utero can be successfully treated with medications with the mother or both. NAS is treatable and has not been associated with long-term adverse consequences. I want to close this discussion about NAS the same way we closed our section about mothers and medication-assisted treatment, and emphasize the importance of reducing stigma. We've learned the importance of language and how being mindful of our language can help reduce stigma for this population. In 2013, 40 leading medical experts sent a letter to several prominent news outlets describing how sensationalized terminology commonly used in the media to describe NAS as medically inaccurate and reinforces stigma. Newborn babies are not born addicted, and referring to newborns with NAS as drug-addicted babies is inaccurate, incorrect, and highly stigmatizing. These newborns may exhibit physiological dependence, but they cannot exhibit the kind of compulsive behaviors associated with addictive disorders. This language reinforces many of the negative attitudes that discourage women from accessing the treatment that they need. Also, portraying NAS babies as victims results in the vilification of their mothers, who are then viewed as perpetrators, and further perpetuates the criminalization of addiction. Using pejorative labels such as oxy babies, oxytots, victims, tiny addict, or born addicted places these children at substantial risk of stigma and discrimination and can lead to inappropriate child welfare interventions. We would recommend rethinking language and using terms that are less stigmatizing and more person-centered. A growing number in the field are using common terminology such as infants with prenatal substance exposure or infants affected by parental opioid use disorders. Your team has the opportunity to re-examine how you view, talk about, and serve women and infants affected by opioid use disorders. We would encourage you to educate partner agencies and your community to reduce the stigma for both the mothers and the babies. Let's talk about how you begin to pull key principles of treatment together into an effective coordinated response. A multi-agency response is needed since no single agency has the resources, information base, or expertise needed to meet the full scale and range of challenges faced by infants with prenatal substance exposure and their families or caregivers. To fully respond to the comprehensive treatment needs of infants with prenatal exposure requires an intensely collaborative effort. Both the scale of the problem and its complexity demand action that is broad-based, interagency, including public and private sectors. Diverse stakeholders play critical roles in detecting and responding to the needs of infants with prenatal substance exposure and their families. The implementation of evidence-based programs by a multidisciplinary team with strong partnerships supports effective use of resources and builds on diverse perspectives. For the Family Drug Treatment Court, it will be important to expand your partnerships beyond the traditional court, treatment, and child welfare systems. In the arena of prenatal exposure and its effects, private service providers, including physicians and their medical staff, hospitals, and pharmacies, also have critical roles. You'll need to invite these onto your team. Leveraging diverse resources coordinated among multiple partners are necessary to comprehensively address the range of needs for infants and families. Leveraging diverse resources coordinated among multiple partners are necessary to comprehensively address the range of needs of infants and families. Ensuring well-trained teams based on trust and accountability is also critical. Since multiple agencies and providers are involved, ensuring strong supportive handoffs for families is also critically important. An essential part of collaboration is agreeing on mechanisms to share information with one another. The barriers such as differences in technological capacity to transfer and link data sets, and private boundaries established by law, practice, and attitudes. Issues of trust may also come into play. Of course, collaboration and coordination across multiple agencies and disciplines can be very challenging work. For many communities, partnering with healthcare providers may be a unique experience that provides new opportunities and different challenges. These professionals may include obstetrician, gynecologist doctors, nurses, neonatologists, NICU staff, hospital social workers, and pediatricians. Some of these professionals work within the private sector and may wonder how federal regulations apply to them. Working with public agencies, such as treatment and child welfare, may also raise concerns about trust and differing values. Many hospitals do not have a clear protocol for notifying the local child welfare agency about infants with prenatal substance exposure, or for consistently identifying and reporting concerns about child abuse or neglect. Sharing information with treatment providers, including those who provide medication-assisted treatment, may also be a challenge for the healthcare systems that generally have very stringent patient privacy guidelines. These are challenges that every collaboration will need to work through. Fortunately, there are resources and examples on how communities have successfully achieved effective collaboration. For information about building a collaborative team, please review the Collaborative Approach publication, which includes a cross-systems guide that you can complete with members of your 5 primary systems. So how will all of these agencies work together on behalf of the mother and baby? What does this unique, expanded collaboration look like? Everything that I've highlighted, the importance of early screening and identification of substance use during the prenatal window, the need for comprehensive and family-centered approaches to the treatment of substance use disorders in pregnant and parenting women, consideration of the responses to infants with neonatal abstinence syndrome that support healthy mother-infant bonding, and the critical role of collaboration lead us to this final key idea I want to share today. We have a tool or an opportunity to pull all of these key concepts together, called a plan of safe care. Each of the key concepts mentioned so far provide a strong framework or foundation to implement what is outlined in the Child Abuse Prevention and Treatment Act related to infants with prenatal substance exposure. The Child Abuse Prevention and Treatment Act, CAPTA, is federal funding that supports prevention, assessment, investigation, prosecution, and treatment activities related to child abuse and neglect. CAPTA has been amended several times. In 2003, amendments added the requirement for plans of safe care for infants affected by prenatal substance exposure. Amendments in 2010 clarified that plans of safe care should include infants with fetal alcohol spectrum disorder. In 2016, amendments were made to CAPTA as part of the Comprehensive Addiction and Recovery Act, also known as CARA. The CARA amendments to CAPTA focused on improving well-being and safety of infants affected by prenatal substance exposure, including through provision of services to their families or caregivers. Requirements were added to emphasize that plans of safe care address the needs of infants who are identified as affected by substance abuse, experience withdrawal symptoms, or have fetal alcohol spectrum disorders, regardless of whether the substance was legal or illegal. Due to this focus on protecting infants through services to both the infant and the family or caregiver, diverse stakeholders play critical roles in detecting and responding to the needs of these infants and their families. So how do communities plan for safe care of mothers and infants? They rely on interdisciplinary partnerships across multiple agencies, including health and social service agencies, as well as child welfare, substance use treatment, and the courts. They're based on the results of comprehensive multidisciplinary assessments and focus services on a family-centered approach that addresses the needs of each family member as well as overall family unit to ensure individual health and successful family functioning. Communities develop plans of safe care prior to the birth event to facilitate engagement and communication among providers as early as possible, reducing the number of crises at birth for women, babies, and systems. Planning efforts include a structure to ensure coordination of, access to, and engagement in services and are grounded in evidence-informed practices. Communication protocols that provide open information sharing across multiple partners involved in the treatment and care of the infants and their family are in place. Ongoing review of the plan of safe care is completed by multiple partners who are aware of the diverse services and partners that the family is accessing. FDCs are uniquely poised to implement plans of safe care since the model embodies many of the key components for effective plans of safe care. So how do plans of safe care differ from other assessments conducted for this population? Plans of safe care differ from child welfare safety plans by moving beyond the immediate safety factors of an infant to addressing their ongoing needs related to health, development, and well-being. Plans of safe care include the substance use disorder treatment plan for the parent, including family-centered treatment and recovery services, but will also incorporate services and supports for diverse, longer-term needs of the parent, infant, and family, including physical and mental health, parenting education, infant developmental screening, and other concrete family support needs. Hospital discharge plans include the education, supports, and linkages needed for a successful departure from the hospital to a home setting. While elements of the discharge plan are important to plans of safe care, such as parenting education and linkages to a medical home, the hospital discharge plan may not include engagement into substance use disorder treatment or consider the safety factors for the infant and plans to address any safety concerns. The plan of safe care brings together various assessments, plans, and service providers in a family-centered plan to ensure the needs of the infant, family, and caregiver are met. By leveraging multiple assessments and case plans, a plan of safe care reduces the number of crises at birth for women, babies, and systems. There are a few reasons why we think FDCs are well positioned to be a part of the development and implementation of plans of safe care. First, the model of FDC is built on interdisciplinary collaboration, leveraging the expertise of multiple systems, which include the risk and safety assessments of child welfare, clinical assessments for treatment services and recovery supports of substance use disorder treatment agencies, and monitoring by the court. FDCs will have to expand services to serve the needs of mothers, infants, and their families. They're family-focused. Agencies with experience, training, and funding focused primarily on children or on adults are challenged by the need to consider both parents and infants in planning services that respond to whole family needs and strengths. This is especially true for developing and managing plans of safe care, which inherently address the needs of both parents and children through interagency and multidisciplinary services. They have a process for information sharing. To achieve the kind of coordination necessary to work across agency, provider, and system boundaries requires clear communication protocols. Information sharing is a key ingredient for the management of plans of safe care. Although individual organizations might assess the family independently, sharing the results with key stakeholders is vital to developing an informed plan of safe care. Partners can execute memorandum of understanding between organizations to facilitate information sharing and avoid problems resulting in conflicting information about health and well-being, safety, progress in recovery, and behavior. Clarifying confidentiality laws that apply to different systems and standardizing informed consent forms compliant with these laws can facilitate information sharing. They're grounded in evidence-informed practices. We've already mentioned that FDCs are well positioned to support or implement plans of safe care. I want to talk further about a range of opportunities for court teams and FDCs. Court programs can support MAT as a standard of care for pregnant women with opioid use disorders by facilitating access and also allowing them to receive MAT while remaining eligible to participate in a court program such as a family drug court. Courts can also accept clinical decisions regarding treatment. Courts can support numerous collaborative and coordinating activities and ensure sharing of essential information and coordination of care for infants. Courts can recognize and support best practices for mother-infant attachment, including breastfeeding. Courts can partner with the Plan of Safe Care coordinator to oversee the development, implementation, or monitoring of plans of safe care. Courts can also provide direct oversight of plans of safe care. It's important to remember that there is a wide variation and no existing template when it comes to developing and implementing plans of safe care. Every community is unique in its partnerships, collaborations, needs, and resources. Today we made the case that working together is necessary to meet the comprehensive needs of infants and their families affected by opioid use disorders. The motivation for this high level of coordination should arise from the acknowledgement that working together produces improved outcomes for children and families, rather than simple compliance with a local MOU or federal legislation. We know what works for these families and what can be achieved when we work together. It's also the right thing to do for children and families. For more information and to continue this discussion, please download the Team Discussion Guide and the Collaborative Approach publication available on this webpage. We'd love to hear from you as you foster collaborative responses across multiple systems to improve safety, permanency, and well-being outcomes for infants, recovery for their parents, and to meet the needs of their families and caregivers. Please contact us at fdc@cffutures.org or visit our website at www.cffutures.org. Thank you for listening.
Thank you for listening to our webinar presentation. To further your learning, please download the webinar discussion guide, which provides questions for your team to explore and next steps and resources to move your team forward. Again, for more information about Children and Family Futures, the Learning Academy, and the FDC TTA program, please visit our website, our Family Drug Court blog, or email us. Thank you, and we hope to see you again here at the Family Drug Court Learning Academy.